Let me just share my screen. Our lesson for tonight is complications of pregnancy. We will be dealing with the most common complications of pregnancy, and these slides are updated with the the most recent book that we have, and that is 2024. Number one, we have here preterm labor. When we say preterm labor, it is a labor, okay, that comes first before the time that you should be giving birth. So ano po ito, ma'am? So when we say, let me just annotate the most important things here. We have here, you're seeing this one, 37th week. Okay, preterm labor is a labor that occurs before the end of the 37th week. Remember that before pregnancy, uterine full term is 38 to 42. Okay, that is your pregnancy uterine full term before, but now we are considering 37 as full term. So pregnancy, uterine full term, pregnancy, uterine full term now starts with 37 37 weeks. Okay, so again, pregnancy, uterine full term now starts with 37 weeks. So any labor that occurs before the end of the 37th week is considered preterm labor. It occurs in 90-11% of all pregnancies, and of course, it could cause fetal death. And if the mother's dilatation is over 1 cm and is 80% effaced, so even if it's only 1 centimeter, and we are familiar that it should be until 10 centimeter, but then again, the effacement is already 80%, and that is already near with 100%. So again, labor now is inevitable at this moment. So could we prevent preterm labor? We have to rest frequently. So as a pregnant woman, you have to rest. Your body is not the same with the body of a woman who is not pregnant. So you're carrying a newborn in you. So you have to be you have to find a way on how to have rest frequently. Another one is drinking 8 glasses or 8 to 10 glasses of water daily. You still remember the things that I have told you, that when you are dehydrated, we're doing this in labor because we want to help the mother to deliver. But again, it's the same thing that if you're dehydrated, your posterior pituitary gland, posterior pituitary gland will stimulate the production of your anti diuretic hormone. You stimulate the production of your antidiuretic hormone, and in response to that, your body will produce oxytocin. So again, we are telling you that you should be drinking 8 to 10 glasses of water daily so that you will not be dehydrated, because when you're pregnant and you will be dehydrated, your posterior pituitary gland will stimulate the production of your antidiuretic hormone, and in response to that, your body will produce oxytocin, and oxytocin would now contract the uterus, and possible it could lead to preterm labor. Another one is you keep yourself mentally active. Okay, so mentally active meaning you should be at least having that peace of mind, and you should not be anticipating things that could happen later. Okay, you should not be having anxiety and fear. Okay, so avoid activities that stimulate preterm labor. Maybe doing a lot of household chores or anything that could stimulate the production of oxytocin, such as sexual acts, like for example, holding the nipple. Holding the nipple could produce oxytocin. And then of course, sexual restrictions. There are positions that you could not assume because you are pregnant. You also have to report signs of ruptured membrane. What is difficult here is when you're trying to report signs of ruptured membrane, it could resemble like your urine. So the mother should be familiar of what it looks like to have a ruptured membrane. And of course, when the membranes are now ruptured, labor is inevitable. And of course, you have to keep appointments for prenatal care. Even though, for example, if the patient or the pregnant client is a nurse or a healthcare provider, still you have to visit your obstetrician for you to be able to know the situation or your condition as a pregnant woman and for you to be able to prevent complications that might occur. Next is we have here, if, for example, uterine contractions recur after all the preventions that you are doing to prevent preterm labor, you have to empty your bladder. You have to empty your bladder, okay? Because a full bladder could be one of the reasons or trigger factors of preterm labor. And you position the mother to left lateral position. So after you emptied your bladder, it will be more comfortable for the mother to be in left lateral position. And again, increase hydration. Again, increase hydration to prevent your posterior pituitary gland in stimulating the production of your anti-diuretic hormone and your oxytocin. And of course, if these are inevitable, you have to contact your healthcare provider. So what are the predisposing factors of preterm labor? This slide should come after the definition of preterm labor. But again, it's just okay. So what will you do? Okay. Or what are the predisposing factors to preterm labor? If you had a previous preterm birth, meaning you will have the possibility to have another previous, or you will have the possibility to have what another preterm labor. Another one is, let me just drink water, guys. Short interval between pregnancies. Okay, short interval between pregnancies could be another reason. Another one, short cervical length. Okay, smoking, and a drug use. This could lead to hypertension and vasoconstriction. And vasoconstriction could be one of the reasons of preterm labor. Another one, perinatal infection, placenta previa. Okay, I will discuss placenta previa later on. Polyhydramnios, overstretching of the uterus. Okay, like your short interval between pregnancies. So there will be overstretching of the uterus, and then later on, um, it could lead to preterm labor, uterine anomalies. Okay, for example, there are anatomical problems of your uterus that could predispose you to have preterm labor, or fetal congenital birth defects. And of course, in all complications of pregnancies, this is always present below the reproductive age. Again, your reproductive age is 18 to 35. Below and above that is leading to a complication, or possibly leading to a complication of pregnancy. So what are the signs and symptoms of preterm labor? It might mimic, right, a true labor pain. So there will be persistent dull, low backache. So, we know that in labor, you will have your low backache, okay? And then you'll have your vaginal spotting, and then later on you will just be like you might like to push because of the pelvic pressure and abdominal tightening. That those are not the signs and symptoms that you are having uterine contractions, and you'll have like feeling of dysmenorrhea, okay? And then increased vaginal discharge would tell you that the operculum, what is that again? We will have your operculum or your mucus plug. Okay, your operculum or your mucus plug. If I let me draw. Okay, for example, this is your uterus and that is your vagina. The mucus plug is white in color, but let me just use a block here. It is white in color, it stays here for the rest of pregnancy. Again, it is white in color, it stays here for the rest of pregnancy to protect the baby against infection. But during labor, okay, it is the reason why we have an increased vaginal discharge, okay? It is the reason why we have an increased vaginal discharge, okay? Because when the blood vessels are now ruptured here, so it will give you a red color, and then plus your operculum or your mucus plug, which is white. So your first vaginal discharge will be pink. So that is the reason why your first vaginal discharge is pink. Okay, so if there will be this increase in vaginal discharge and you know that the baby is going down. So the baby is going down. Another one, you have uterine contractions. The duration, intensity, frequency, and interval of uterine contractions is now progressing. That is why you will have also intestinal cramping. So the contractions will give you the pelvic pressure, it will give you the abdominal tightening, it will give you the intestinal cramping, and it will give you the low backache. And of course, it will cause you pain. Okay. Next is how to check for the possibility of preterm labor. For us in the Philippines, we are just using the ultrasound. Okay, we're just using the ultrasound. But for other countries, they have their own ways. Okay, this is actually new. They have their own ways on how to check it. They will have the vaginal mucus analysis for fibronectin. Fibronectin is a protein produced by the trophoblast cells. So, what are your trophoblast cells? What are your trophoblast cells? The trophoblast cells are the one who uh, that produces your human chorionic gonadotropin, okay? Your HCG, your human chorionic gonadotropin. So this must be tackled in OB1. So you have your human chorionic gonadotropin. So the presence of this one will predict that preterm contractions will occur, and its absence predicts that labor will not occur for the next 14 days. So they Yes, technically, they are doing this test for them to be able to note if there is the possibility of preterm labor, and they will be doing ways to prevent it, okay, or to prevent the occurrence of preterm labor. So what will you do if, for example, um, preterm labor is really occurring? So you can still stop labor, provided that the fetal membranes have not yet ruptured. Kasi if your amnion and your chorion are or already ruptured, then labor is inevitable. But in cases wherein your membranes are not yet ruptured, then you could just you could still save the baby. There's still the possibility. And of course, if there is no fetal distress, meaning there is no abnormality in your FHT, remember your FHT is 120 to 160, okay? 120 to 160. So if there are no abnormalities, okay, you could still stop labor. And there is no evidence that bleeding is occurring, meaning the labor is not progressing. And if the cervix is not dilated beyond 45 and the effacement is not more than 50%, meaning there's still a possibility to save the baby. Of course, we don't want preterm labor because the baby is also preterm, okay? So the life of the baby might also be at risk. So we have here, let the patient be admitted. Why? The patient needs bed rest. And of course, your external fetal monitoring, remember your external fetal monitoring is with the use of your cardio, okay? Your cardio topography machine, with the use of your cardiotocography machine or your CTG, okay? So they will have to hook the mother um, on the CTG so that they would know the fetal well-being. IVF therapy so that you will have a lifeline, okay? Or they will have to rule out infection because UTI, as per by the book, the causative agent of UTI is also fatal to the newborn, and that could cause preterm labor. UTI is highly related to preterm labor for unknown reasons. Okay, so you could still give your tocolytic. So let me just discuss this one. Give emphasis to what is new. So you have here your terbutaline. Ayan. Minsan narorong spelling pa si ma'am. Ayan. So you have your terbutaline. So the warning is you could not give terbutaline for more than 48 to 72 hours or um 3 days. Kasi si terbutaline, one of the side effects of terbutaline is your tachycardia. These are common board exam questions. Okay, so you will have the side effects of your terbutaline is your tachycardia. So again, if you will give it for more than 3 days, then it could lead to cardiac arrest and of course a death. Okay, your magnesium sulfate was then one of the um Tocolytics, but now it's no longer used because they found out that the patients who are taking magnesium sulfate to prevent preterm labor and those who are not taking will have no differences. But again, another finding for magnesium sulfate, it is used now for your neuroprotection prior to 32 weeks, and it helps prevent cerebral palsy in premature infants. So still there will be giving of magnesium sulfate, but it is no longer as a tocolytic, but this time it is used for neuro protection of the baby or your fetal neuroprotection before the 32nd week of pregnancy to prevent cerebral palsy. But if you um, encounter that the drug of choice of your hypertensive, hypertensive disorders, okay, disorders in pregnancy, okay, your hypertensive disorders in pregnancy, okay, the drug of choice is still magnesium sulfate. So magnesium sulfate is not only for the prevention of cerebral palsy, but it is also the drug of choice for hypertensive disorders in pregnancy. So again, magnesium sulfate is not, it's no longer a part of the tocolytic group of therapies. Okay, another one hindi yata nilagay dito. You also have your Ritodrine. So your Ritodrine is one of the safest kasi si Ritodrine is also one, okay, of the tocolytics. So we have terbutaline and Ritodrine, but the safest is Ritodrine because terbutaline again could lead to cardiac arrest because the side effect of terbutaline is tachycardia. So again, in the board exam, when you are to give terbutaline, you have to check first for the heart rate of the patient before giving. And this one, I really intended to wrote this one in the PPT, okay, for reasons not clearly understood. If in the time beginning between when the preterm contraction and preterm birth, of course, the patient is administered a corticosteroid, they are given your betamethasone and your dexamethasone, okay? The formation of lung surfactant appears to accelerate. So what are your lung surfactants? Do not forget your lung surfactants. You have your lecithin. Wait lang. I hope I will not be having a wrong spelling. You have your lecithin. Your sphingomyelin. Your phosphatidylglycerol. Phosphatidyllinositol. And phosphatidyl phosphorus. So this is how the book is spelled it. So, okay. Again, you have your 5 lung surfactants. Your most abundant, you have your lecithin, you have your sphingomyelin, and then you have your phosphatidylglycerol, which is the most important, okay, when you are checking the lung surfactant of a mother with gestational diabetes mellitus, and you also have here your phosphatidylinositol and phosphatidylphosphorus. So it has been found out that when you're giving the corticosteroid betamethasone and dexamethasone, the lung surfactant formation accelerates, and of course, this now decreases the possibility of respiratory distress syndrome or bronchopulmonary dysplasia. So we have here betamethasone. It is given in 12 milligram once a day for 2 doses, and dexamethasone 6 milligrams twice a day for 4 doses. So dito, you have to take note that any of this drug could be given for 2 days. Okay, any of this drug could be given for 2 days when you say A, B, betamethasone. Okay, so betamethasone could be 2 doses, meaning you're giving 12 milligrams a day. So for dexamethasone, you have your A, B, C, D. Okay? A, B, C, D, meaning dexamethasone, you are giving it for 4 doses. Okay, so 4 doses in 2 days, meaning you are to give 6 milligrams twice a day. So, for example, if you're thinking of which of them is 12, which of them is 12 or 6. So you have to take note that if it's given twice a day, it would be for a larger dosage. And if it's given for 4 times a day, or 4 doses, okay, or twice a day for 4 doses, meaning the the dosage of the drug is lower. So we have here again betamethasone A, B. So betamethasone, again, there are 2 corticosteroids given to patient in preterm labor so as to prevent respiratory distress syndrome to the baby. So two drugs, what are those two drugs? Two drugs given for 2 days. So any of them, they could give betamethasone A, B, meaning betamethasone is given for 2 doses, meaning you're giving once a day, okay? You're giving once a day for 12 milligrams. And then you will have dexamethasone A, B, C, D. Okay, so 4 doses, meaning you're giving it twice a day and you're giving 6 milligrams. Okay, so the effect of betamethasone will only last for 7 days. And then if, for example, the baby, okay, do not forget that the effect of betamethasone, it's written in the book, it will start after 24 hours. And then, for example, if the baby is not born within 7 days, then you have to what? You have to repeat, okay? And then repeat the dose of the betamethasone. And another one is you have your betamethasone interferes with the glucose regulation for both the parent and the fetus. These are now the side effects of betamethasone. Again, it interferes with a glucose regulation of the baby and the mother. So we have now here the topics of hypertensive disorders in pregnancy. Okay, this now comes first before the other topics. Kasi the hypertensive disorders in pregnancy before it was called your toxemia in pregnancy. Doctors are not aware, or the doctors are finding reasons why the mother is having a high blood pressure on the second and third trimester. So in every pregnancy, we have 3 trimesters. We have first, second, and third trimesters. So the doctors are trying to find out the reasons why the mothers will have what high blood pressure or elevated blood pressure on the second and third trimester, and then they wrote it before that it might be because of toxemia or the presence of toxin in the blood. And then later on, toxemia was called your PIH, or your pregnancy-induced hypertension. Okay, these are the different versions of Pilitarian flag. Okay, but for the hypertensive disorders in pregnancy, this is already a version of flag in 2022. So we have here pregnancy-induced hypertension. So we have here, pag sinabi nating pregnancy-induced hypertension, before it was classified into gestational hypertension, preeclampsia, and eclampsia. And then there was a time that it was labeled as gestational hypertension. Okay, it was labeled as gestational hypertension until for 2022 and 2024. And of course, now at the moment, we are now having this term hypertensive disorders in pregnancy. So the pathophysiology presented by Pilitary before, until the book was authored by Flag, and after the eighth edition kasi was the first seven editions were authored by Pilitary, and then the eighth edition was authored by Pilitary and Flag, and the ninth edition was authored by Flag. So the pathophysiology is still the same. So we just have to discuss the new term hypertensive disorders in pregnancy, and this one greatly affects your kidney, brain, liver, placenta, and the pancreas. So we have here kidney, brain, liver, placenta, and the pancreas. These are the first organs, okay, that are being destroyed or affected when we have hypertensive disorders in pregnancy. Before the actually the cause is unknown until this moment. It's idiopathic, okay. But then again, before, the first or the number one predisposing factor of pregnancy-induced hypertension was nullipara. Okay, it was nulliparity before. Kasi what was the justification of this is they conducted a study from 1933 to 1987, and they found out that all the nullipara, okay, okay, or most of the nullipara, um and or the respondents, 70% of them developed pregnancy-induced hypertension. That now made them decide that nulliparity is the number one predisposing factor to pregnancy-induced hypertension. But for now, we have an update that it is because of your APAS. Minsan it is APAS, minsan it is antiphospholipid syndrome. Actually, this is new. Okay, we'll have a different discussion with this one. So you have actually it's not only causing your hypertensive disorders in pregnancy, but it is now related to abortion. So your antiphospholipid syndrome or your APAS, antiphospholipid antibody syndrome. So it could be your APAS or your APS, okay? So you have here the presence of antiphospholipid antibodies. So they have found out that it could be the number one really predisposing factor of hypertensive disorders in pregnancy. And being a person of color, meaning these are the black, okay, experiencing multiple pregnancy, you're twinning. Remember that your twins is now considered a complication of pregnancy. Again, with the reason that the human body could only um, take good care of one child at a time, okay? Being a primiparous, so it might be related to nulliparity that was found out before as the reason for PIH, okay? So if it's your first time to get pregnant, if you're less than, may it be you are a young primigravida, okay? May it be you're a young primigravida or you are an old primigravida. So if you are a young primigravida and an old primigravida, both of those reasons could be predisposing factors to the development um, of hypertensive disorders in pregnancy. Or another one is having come from a low socioeconomic background. This was related to very low protein intake from my other readings. It is related to a low protein intake, which may lead to a history of poor nutrition and having a status of gravida 5 or more. So multigravida and primigravida are both possible reasons or predisposing factors to hypertensive disorders in pregnancy. And this one, another one is experiencing polyhydramnios. Uh, Still, Flag did not explain why polyhydramnios could be related to hypertensive disorders in pregnancy. And it's number 9. This was one of the longest predisposing factors that have been studied that there might be an effect of your heart diseases, diabetes, or renal involvement, or essential hypertension, meaning your uh, comorbid conditions, okay, might predispose you to have your pregnancy-induced hypertension or your hypertensive disorders in pregnancy. So I intended to cut and paste, okay, to take a picture of what is really in the book of Flag as the latest that we have right now for this one. And the same pathophysiology as what I've mentioned to you a while ago, the pathophysiology is still the same. So it started with vasospasm. Okay, it started with vasospasm. When you say vasospasm, the dilatation and vasoconstriction ratio of your blood vessels, okay, is not good. So there could be the possibility of sustained hypertension. And if this vasospasm would affect your blood vessels, you'll have vascular effects and then you'll have vasoconstriction and of course poor organ perfusion. And when there is poor organ perfusion, alam natin that automatically will have an increased blood pressure. And when your vasospasm hit your kidneys, there will be decreased glomerular filtration rate. And this decreased glomerular filtration rate will be the reason of your decreased urine output. Okay, again, your decreased glomerular filtration rate will be the reason of your decreased urine output. Another one is you have here increased permeability. Okay, increased permeability of the glomerular membranes. When you say the glomerular membranes, okay, for example, these are your glomerular membranes, okay, and this could be a protein, okay. Protein should stay in the body for the purposes of oncotic or osmotic pressure, meaning if these are two compartments of the body, this is your blood and your body fluid, okay, protein is needed for oncotic or osmotic pressure, okay? For oncotic or osmotic pressure, so there will be no mixing of the blood and the body fluid. Kasi if the blood and body fluid will mix, it will lead to what? To edema. Okay, so what will happen in the increased permeability of glomerular membranes? So if there is increased permeability, this will become wider and protein could now pass through it and protein will be in the urine. If protein will be in the urine, the patient will have what? Proteinuria. So if the patient will have proteinuria, if protein is already in the urine, what will happen? Okay, if these are two compartments, I'm sorry for that one. If these are two compartments now, you have your blood and body fluid, and protein is already nearly absent in the body, nothing will strengthen, okay, the osmotic or oncotic pressure. So what will happen? There will be mixing, okay, say interstitial and interstitial, there will be diffusion of fluid into the bloodstream. So we'll have edema. So edema particularly is because of your increased permeability of the glomerular membranes that cause your proteinuria. So what are the triad symptoms? When the board exam will ask you what are the triad symptoms of your hypertensive disorders in pregnancy, are your hypertension, edema, and proteinuria. So you have your triad symptoms, you have your hypertension, edema, and proteinuria, okay? So it started all with vasospasm. Again, what are the triad symptoms? You have your hypertension, edema, and proteinuria or your HEP. Another one, you have here the number one type of hypertensive disorders in pregnancy. You'll have your gestational hypertension, and of course, it is caused by primarily vasospasm. And this vasospasm will lead to hypertension. The mother will have the BP of 140/90 in 20 weeks, but the patient will not develop proteinuria and edema. So if there is no edema and proteinuria, particularly this is your gestational hypertension. But then again, if the patient develops gestational hypertension before full term, but does not progress to preeclampsia, they should be induced 37 weeks of gestation. Why? Because the book still believes that when the products of conception, what are the products of conception again? And pertaining to your, when you say products of conception, you have your baby, placenta, you have your membranes, your chorion and amnion, and you have your umbilical cord. When you say products of conception, you have your baby, placenta, umbilical cord, amnion, and chorion. Okay, so those are the products of conception. So if the woman will develop a blood pressure of 140/90 in 20 weeks or before the woman will have the fifth month of pregnancy and there's still no um, proteinuria or edema, then you may have to deliver the baby before the 37th week or on the 37th week of pregnancy, so we will not have the preterm one. Okay, so why do we have to induce? Because the book still believes that when the products of conception is already or are already out of the body, then there will be no reasons for the mother to have hypertension. So that is one of the management. Okay. Next is we have here preeclampsia without severe features. When we say preeclampsia without severe features, okay, this one you have to take note. If there is seizure from preeclampsia, um, meaning later on the patient will have eclampsia. So later we'll talk about seizure, eclampsia, and preeclampsia. So let's focus more on preeclampsia without severe features, any status above gestational hypertension, and before seizure. Kasi seizure is already happening or will only happen if the patient will have what? Eclampsia. Okay? So if, for example, the patient will have hypertension accompanied with proteinuria, so that is now your preeclampsia without severe features. Okay, what are the signs and symptoms of your preeclampsia without severe features? You have here a positive on a urine dip of or 300 milligrams in the 24-hour urine protein collection, or there might be a 0.3 or higher on a urine protein creatinine ratio, or the BP is 140/90 taken on two different occasions 4 hours apart for us to be able to know if the hypertension is already leading to preeclampsia without severe features, or it could be coming from another reason, or if the systolic is greater than 30 mmHg and diastolic is greater than 15 mmHg. So what are these things? So, ma'am, what are these? What are you trying to tell us? So when we say, diba, I have mentioned before that when, okay, sorry, I will just have to change the color. Okay, we have mentioned before that we have the pre-pregnant vital signs, okay? Pre-pregnant BP. So when the pre-pregnant BP, for example, is 90/70, and it now becomes um 120 over 80. So if you will subtract this two, okay, so 120 minus 90 is already how many? 30 mmHg. Tama? Okay, it's 33 mmHg. And 80 minus 70 is already 10. So the 10 mmHg. So this one, if the systolic is greater than 30 mmHg and the systolic is greater than 15, so this is preeclampsia without severe features. So this is not yet considered um preeclampsia without severe features because it's still 30 mmHg. So when we say preeclampsia without severe features, that might be so if this becomes 40, mom, this is just 40 and the diastolic is 10, it's okay when one of these two things, okay, are elevated. So meaning even if the diastolic is just 10 and then the systolic is more than 30, it is still considered preeclampsia without severe features. Okay, so take note. Okay, I'm sorry for that one. Okay, take note that we have to bear in mind the pre-pregnant BP of the patient for us to be able to know if there is already the presence of preeclampsia without severe features. Again, if the systolic is greater than 30 mmHg and the diastolic is greater than 15 mmHg. So what will you do for preeclampsia without severe features? You will just have to monitor antiplatelet therapy, mild antiplatelet agent, and low-dose aspirin, and of course, provide emotional support so that the patient will not develop preeclampsia with severe features and eclampsia later on. Okay, so what is this one? When we say preeclampsia without with severe features, these are now the characteristics. Okay, the BP is 160. Okay, the BP is 160 over 110. So I had this before. Okay, I am already into turning into eclampsia before. Okay, taken into occasions, and then the platelet count is less than 100,000. Then the patient will have elevated liver enzymes twice as the normal upper limit. And you have here serum creatinine above 1.1. The patient might have pulmonary edema. Okay, before in eclampsia we only consider pulmonary edema in eclampsia, but now pulmonary edema could be present in preeclampsia with severe features. And then you'll have a headache not relieved by any medication or analgesic or visual disturbances, like when the patient is telling you that she is seeing falling curtains, okay? Falling curtains. Pag sinabi niya, may nahuhulog na parang cortina na, okay? So that is visual disturbances in your preeclampsia with severe features. So what is present in preeclampsia with severe features that is not present in preeclampsia without severe features is now the presence of your pulmonary edema. Okay. Another is what will you feel in preeclampsia with severe features, like an epigastric pain. So when the pain is in the epigastrium and then the patient is having nausea and vomiting and pulmonary edema or the shortness of breath. The shortness of breath is characterized by difficulty of talking. Okay. Okay, like that. Okay, so we'll have cerebral edema. Okay, the cerebral edema could start from, again, the cerebral edema could be coming from another problem, but it could lead to blurred vision, hyperreflexia, and ankylosing. Before kasi the discussion of cerebral edema is cerebral edema could only be present if there is convulsion. Okay, convulsion is 39 degrees Celsius. Okay, that could cause cerebral edema. But now, the cerebral edema could come first before it could turn into convulsions or to eclampsia. Okay, nursing interventions, what will you do? Of course, you have to admit the patient. And if the patient is less than 34 weeks, meaning the surfactant is not yet formed, because the formation of lung surfactant starts from 28 weeks. It starts from 28 weeks to 34 weeks. So if it's less than 34 weeks, then you might have to alleviate the symptoms because we could not still deliver the baby. Why? The baby is still not, the lung surfactants of the baby is not yet developed. So there might be a lesser viability of the baby if the baby is delivered this time. Another one is you have to support bed rest. Okay, of course. no visitors during hospitalization to decrease the stress of the patient. And you have to raise the side rails for the possibility of seizures. We have to darken the room. Why? We have to darken the room because we don't want to stimulate the patient. Because when the patient is being stimulated, then there could be the possibility of seizures. That is one of the um, um, ano na to, that could be one of the predisposing factors to seizures. Again, if the board exam will ask you where will you place a patient with hypertensive disorders in pregnancy, always place the patient, okay, on bed 1. Okay, why bed 1? Near the nurse's station for you to be able to note the changes, okay? For you to be able to note the changes in the patient. For example, if the patient will be developing other symptoms leading to eclampsia, then we'll have we could observe them to prevent these complications. Avoiding stress, monitor well-being of the baby and the mother, take the blood pressure regularly for us to know the possible elevation, obtain blood studies for possible, of course, blood transfusion later on or other reasons that might be causing, okay, the the hypertensive disorder in pregnancy. Place an indwelling catheter because we have to measure the output. We have to measure the output of the patient because later on we might be giving magnesium sulfate, and before we could give magnesium sulfate, we have to know the output of the patient, and of course monitor the well-being of the fetus. So monitor the well-being of the fetus and the mother. Next is, wait lang. What will you do for this one? You have to administer magnesium sulfate. So we are still taking the notes from flag and military that when you give magnesium sulfate, you have to check for RUR. So what is RUR? Number one, you have to detect, okay, or check for the reflex. So what is this reflex? This is your deep tendon reflex, and the deep tendon reflex should at least be, okay, the deep tendon reflex should be double positive, okay, before you give magnesium sulfate. And then of course you have to check for the urine output. This is now the reason why you are placing the indwelling catheter. So the urine output of the patient, must be, okay, 30 ml per hour, or 100 100 ml in 4 hours, or 100 ml in 4 hours. And of course, you have to check for the respiratory rate. You have to check for the respiratory rate. The respiratory rate must be at least, okay, the respiratory rate must be at least 12 ppm. Okay, the respiratory rate must be at least 12 ppm. Take note, dear nurses, do not give magnesium sulfate when any of this is abnormal. Okay, do not give magnesium sulfate if any of this is abnormal. Like for example, you have deep tendon reflex double positive, you have urine output of 30 ml per hour, but your RR is 11 or 10, then do not give magnesium sulfate. So initially, before, we are giving 16 cc IV of magnesium sulfate. This is the initial dose. Okay, initially we're giving 16 cc IV, and then of course 10 cc 10 cc IM per buttocks, okay, per buttocks. Before we are using, or we are having the upper gluteus maximus as the area where we inject the medication, but for now we are using the ventral muscle. For this one, we are using the ventral muscle. So the patient must be in standing position, okay? Standing position with uh, cross feet, okay? Cross feet for us to be able to locate for the ventral muscle. So it has been found out in your evidence-based practice that when you are injecting magnesium sulfate in the ventral muscle, the patient will have lesser pain. And when the patient will have lesser pain, there is a lesser tendency of developing your seizure. Okay, we have here hydralazine. Hydralazine is used to lower down the BP of the mother. Okay, magnesium sulfate kasi is given for convulsions. Okay, it is given for convulsions. Magnesium sulfate is given for convulsions. That is why this is the drug of choice for what? For um hypertensive disorders in pregnancy. Okay, we have here calcium gluconate. The calcium gluconate must be 10%. Okay, the calcium gluconate, this is the antidote. Okay, this is the antidote. This is the antidote to magnesium sulfate toxicity. To magnesium sulfate toxicity. It must be always present in the bedside when you are giving magnesium sulfate. So how would you know that there is MgSO4 toxicity? Okay, or hypermagnesemia, okay, or let me just, okay, hypermagnesemia, how would you know, okay, that there is already magnesemia, okay, or very high magnesium sulfate in the body if there is already negative, okay, if there is already negative deep tendon reflex. So meaning if there is already negative deep tendon reflex, there is magnesium sulfate toxicity. So we are giving calcium gluconate 10% as the antidote, okay, because magnesium sulfate toxicity could lead to respiratory arrest. Okay, so if you're eclampsia, what is the difference of eclampsia from the signs and symptoms of your preeclampsia with severe features and preeclampsia without severe features is the presence of convulsion. Okay, it is the presence of convulsion. Again, what is it? It is the presence of convulsion. It is now the one giving the patient the possibility convulsion. Okay, the patient's having 39 degrees Celsius, okay, 39 degrees Celsius, okay, for the temperature. And this one could lead to cerebral edema or even CNS hemorrhage, okay, or even CNS hemorrhage. And this one, it could lead to tonic-clonic seizure, and the mortality rate is 20%. So the prognosis of the fetus is very poor because the fetus could have abrupt placenta because of vasoconstriction, and vasoconstriction, okay? Vasoconstriction, and this vasoconstriction maybe because of a very high blood pressure, maybe because of a very high blood pressure. So again, abruptio placenta is the separation of the placenta from the point of implantation before the birth of the baby. So we have here, again, the most severe classification is your eclampsia. Next, what are your nursing interventions for your eclampsia? You have to watch out for an aura. Okay, so you have to know what are the possible aura of the convulsion. That is why a while ago, you have to say erase the side rails for the patient not to fall down. You have to administer your diazepam or your Valium. Your diazepam or your Valium is given to prevent your seizures. It is given to prevent your seizures. And you have here nursing interventions. You have to manage tonic-clonic seizures. According to the book, there are only two um, classification of this seizure. You only have you have your mild and your severe. And when you say it's mild, when the seizure is already 1 to 2 times, and then when you say severe, when the seizure is already 10 to 20 times. So what will you do here is you have to prevent the first onset of the seizure, because when the patient already had started having seizure from 1, it could stop to 20, meaning there is no way to stop when the seizure is already there. That's according to military before. So we have the classification, mild and severe. For mild, it's 1 to 2 times. For severe, is 10 to 20 times. Another is you have to monitor the blood pressure even after postpartum, because there's a possibility of residual hypertension or pinakama pinakamalas is when you will have your secondary hypertension later on. Here are the summary of symptoms. Okay, here are the summary of your symptoms. Wait lang. Okay, so this is coming from the book of military. For gestational hypertension, do not forget that you only have a high BP, but you may not have your proteinuria and edema. But for preeclampsia without severe features, these are also the signs and symptoms. The preeclampsia with severe features with the presence of pulmonary edema. And of course, thrombocytopenia, yun yung what we are telling you a while ago, that the platelet is already below 100,000. And eclampsia, of course, preeclampsia, the presence of seizure and convulsions. Do not forget the presence of seizure and convulsions. Again, these are your the table 216 should not be symptoms of gestational hypertension, it should be symptoms of hypertensive disorders in pregnancy. Maybe this is just a typo error from a flag, okay? Because what you see here in table 21.6 are the types of hypertensive disorders in pregnancy, not the type of gestational hypertension. Okay, so that's the end of the lecture for tonight. I hope to see you once again, okay? I hope to see you once again in our next lessons. Thank you so much.